Good afternoon and welcome to today's program, Tobacco Use and Addiction Treatment, Debunking the Myths and Becoming Tobacco-Free. I'm Julie Miller, Editor-in-Chief of Addiction Professional Magazine. Today's program is sponsored by CeDAR. Thank you to our sponsors and to everyone in our audience for giving us your time and attention today. Before we get started, we do have a few housekeeping details. You'll notice that each window on your screen can be moved by clicking and dragging, or can be enlarged and minimized by clicking on the icons in the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time. You don't have to wait until the end of the program. If you can't see this area, simply click the red Q&A button. To download a copy of today's presentation to have for yourself, please click the link in the Resources area in the lower left of your screen. If you have any technical issues at all during the program, please click the yellow Help button and we will definitely help you troubleshoot the issue. A special note about CE credit. To receive credit for today's program, you must click the green CE certificate widget at the conclusion of the program and complete the evaluation form. If you're watching today's program in a group, please download the group submission guide and program evaluation form located in today's resources list and follow the instructions. If you have any issues with this process, please do not reach out to today's sponsor. They will not be able to assist you. We have that information. So also please note that CE credit is not available for the archived webinar. It is only available for the live event today. And finally, you can also tweet during today's webinar via Twitter by clicking on the blue Twitter icon at the bottom of your screen. Simply click the Post and Authorize buttons to log into your Twitter account and begin sharing automatically at the event hashtag #APLiveWebinar. And now it's my pleasure to introduce our speaker, Laura Martin, MD. Dr. Martin is an Associate Professor of Psychiatry at the University of Colorado School of Medicine. She conducts research on the effect of nicotine agonists and other interventions on tobacco use in individuals with substance use disorders and other mental illnesses. She's also involved in the development and implementation of curricula for tobacco cessation, general behavior change, and provider wellness. As Medical Director at the Center for Dependence, Addiction, and Rehabilitation, a residential outpatient alcohol and drug treatment center, she regularly works with individuals with both substance use disorders and other mental illnesses to improve their physical and mental health. She also played a critical role in CeDAR's successful transition to being a tobacco-free residential substance use disorder treatment center. Dr. Martin is a board-certified psychiatrist, addiction medicine specialist, and Distinguished Fellow of the American Psychiatric Association. And with that, thank you, Dr. Martin, for taking the time to speak with us today. I will turn the audience over to you.
Thank you, Julie, and thank you for the opportunity to present on this webinar today. Welcome to everybody who's attending. I super appreciate your interest in this topic. And as we get started, I do want to make sure that you're aware of a few disclosures that I have. I have received salary support from the Veterans Affairs Career Development Award Program, the Brain and Behavioral Research Foundation, and Pfizer Pharmaceutical Company to study the effects of nicotine and nicotinic agonists on human electrophysiology, brain imaging, and smoking behavior. I'm the Medical Director at CeDAR. We are a residential and outpatient addiction treatment center that's associated with the University of Colorado Hospital. And during the time that we went through our tobacco-free transition, I was also the medical director of the Behavioral Health and Wellness Program. And we followed a toolkit that they produced. And I wanted to make individuals aware of this organization because they have a lot of great free toolkits related to becoming tobacco-free programs as well as well-body initiatives. And this work was made possible by the vision of the CeDAR Clinical Excellence Committee and Administration, close consultation with the Behavioral Health and Wellness Program, the hard work of our Wellness Committee, the hard work of the entire CeDAR staff, who were and are amazing and inspiring in the implementation of this work as well as other work, and the even harder work of our patients, who are equally amazing and inspiring. With today's learning objectives, I would like you all to be able to summarize the prevalence, morbidity, mortality data related to tobacco use disorders in the general population and individuals with substance use disorders, to be able to identify barriers to treatment of tobacco use disorders, to be able to discuss key outcomes following the transition of CeDAR to being a tobacco-free program, as well as to be able to discuss the pros and cons of electronic cigarettes. So to begin, I wanted to review recent and not so recent trends in adult smoking. As you can see from this graph, since the 1950s to 1960s, we've had a steady decline in the number of individuals, both male and female, who are currently smoking. And we're about 19% of adults are current smokers. And this decline is starting to level off, and we would like to further reduce the number of individuals who are using tobacco, because we know that individuals who use tobacco lose on average 10 years of their lives. If an individual has a behavioral health disorder, we know that they lose up to 25 years of their life. And we really want to help improve the lives of these individuals from both a mental and a physical standpoint. And if we look at these next charts, these are the age-specific proportion of participants by smoking status. And on the left are points representing women. On the right are points representing men. And the yellow line are individuals who have never smoked. And you see that's
Good afternoon, and welcome to today's program, Tobacco Use and Addiction Treatment, Debunking the Myths and Becoming Tobacco-Free. I'm Julie Miller, Editor-in-Chief of Addiction Professional Magazine. Today's program is sponsored by CeDAR. Thank you to our sponsors and to everyone in our audience for giving us your time and attention today. Before we get started, we do have a few housekeeping details. You'll notice that each window on your screen can be moved by clicking and dragging, or can be enlarged and minimized by clicking on the icons in the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time. You don't have to wait until the end of the program. If you can't see this area, simply click the red Q&A button. To download a copy of today's presentation to have for yourself, please click the link in the Resources area in the lower left of your screen. If you have any technical issues at all during the program, please click the yellow Help button and we will definitely help you troubleshoot the issue. A special note about CE credit. To receive credit for today's program, you must click the green CE certificate widget at the conclusion of the program and complete the evaluation form. If you're watching today's program in a group, please download the group submission guide and program evaluation form located in today's resources list and follow the instructions. If you have any issues with this process, please do not reach out to today's sponsor. They will not be able to assist you. We have that information. So also please note that CE credit is not available for the archived webinar. It is only available for the live event today. And finally, you can also tweet during today's webinar via Twitter by clicking on the blue Twitter icon at the bottom of your screen. Simply click the Post and Authorize buttons to log into your Twitter account and begin sharing automatically at the event hashtag #APLiveWebinar. And now it's my pleasure to introduce our speaker, Laura Martin, MD. Dr. Martin is an Associate Professor of Psychiatry at the University of Colorado School of Medicine. She conducts research on the effect of nicotine agonists and other interventions on tobacco use in individuals with substance use disorders and other mental illnesses. She's also involved in the development and implementation of curricula for tobacco cessation, general behavior change, and provider wellness. As Medical Director at the Center for Dependence, Addiction, and Rehabilitation, a residential outpatient alcohol and drug treatment center, she regularly works with individuals with both substance use disorders and other mental illnesses to improve their physical and mental health. She also played a critical role in CeDAR's successful transition to being a tobacco-free residential substance use disorder treatment center. Dr. Martin is a board-certified psychiatrist, addiction medicine specialist, and distinguished fellow of the American Psychiatric Association. And with that, thank you, Dr. Martin, for taking the time to speak with us today. I will turn the audience over to you.
Thank you, Julie, and thank you for the opportunity to present on this webinar today. Welcome to everybody who's attending. I super appreciate your interest in this topic. And as we get started, I do want to make sure that you're aware of a few disclosures that I have. I have received salary support from the Veterans Affairs Career Development Award Program, the Brain and Behavioral Research Foundation, and Pfizer Pharmaceutical Company to study the effects of nicotine and nicotinic agonists on human electrophysiology, brain imaging, and smoking behavior. I'm the Medical Director at CeDAR. We are a residential and outpatient addiction treatment center that's associated with the University of Colorado Hospital. And during the time that we went through our tobacco-free transition, I was also the medical director of the Behavioral Health and Wellness Program. And we followed a toolkit that they produced. And I wanted to make individuals aware of this organization because they have a lot of great free toolkits related to becoming tobacco-free programs as well as well-body initiatives. And this work was made possible by the vision of the CeDAR Clinical Excellence Committee and Administration, close consultation with the Behavioral Health and Wellness Program, the hard work of our Wellness Committee, the hard work of the entire CeDAR staff, who were and are amazing and inspiring in the implementation of this work as well as other work, and the even harder work of our patients, who are equally amazing and inspiring. With today's learning objectives, I would like you all to be able to summarize the prevalence, morbidity, mortality data related to tobacco use disorders in the general population and individuals with substance use disorders, to be able to identify barriers to treatment of tobacco use disorders, to be able to discuss key outcomes following the transition of CeDAR to being a tobacco-free program, as well as to be able to discuss the pros and cons of electronic cigarettes. So to begin, I wanted to review recent and not so recent trends in adult smoking. As you can see from this graph, since the 1950s to 1960s, we've had a steady decline in the number of individuals, both male and female, who are currently smoking. And we're about 19% of adults are current smokers. And this decline is starting to level off, and we would like to further reduce the number of individuals who are using tobacco, because we know that individuals who use tobacco lose on average 10 years of their lives. If an individual has a behavioral health disorder, we know that they lose up to 25 years of their life. And we really want to help improve the lives of these individuals from both a mental and a physical standpoint. And if we look at these next charts, these are the age-specific proportion of participants by smoking status. And on the left are points representing women. On the right are points representing men. And the yellow line are individuals who have never smoked. And you see that's running about 65 to 80% of the population. In blue, you see these are current smokers. And I'd like to highlight what all of you are already aware of, but I don't think we identify on a day-to-day basis, is that smoking and tobacco use are disorders of youth and young adulthood that decline as individuals age. And as you can see from the red line, that is because some individuals are able to quit smoking. And also, unfortunately, as we get to later ages, 60s, 70s, 80s, the individuals who are still smoking are dying prematurely. The other thing that I would like to point out with this chart is that when we think about this rising number of former smokers we see, the men tend to stop smoking at higher rates than the women, and this is important in your smoking cessation efforts to note. The other thing that I'd like to point out is that as individuals age, we see a higher likelihood of individuals having a co-occurring behavioral health disorder in addition to their tobacco use behavior, so it's really important to screen for that. And this is, again, highlighted in the next slide in that individuals with substance use disorders are more likely to smoke. And this is some data that was presented in 2013 that looks at the percent of individuals who smoke. And on the left side of the chart, if we look at the general population, we see that number just under 20%. If we look at individuals with a lifetime history of drug or alcohol use disorders, that number goes up to 30 to 40%. If we look at past year history of a drug or alcohol use disorder, that number jumps up to between 30 and 50%. And if we look at past year treatment, so being actively involved in substance use disorder, this is an incredibly high-risk group for smoking behavior, up to 60% of those individuals. If you also have other co-occurring behavioral health disorders, these numbers go up even higher. And if we think about the cost of tobacco dependence, mortality rates are huge. I already mentioned the on average 10 years of life lost for smokers. If you've got a behavioral health disorder, there's about 2.5 decades of life lost. And when we look at behavioral causes of mortality, which this slide highlights, to the right, we see much, much, much higher rates of mortality that are associated with obesity and tobacco. And you can even combine all these other causes of mortality and not reach the numbers with these two illnesses. And on the tobacco column, you'll see that there's a black dash and star. And what that represents is that about half of the tobacco use disorder related deaths are in individuals with behavioral health disorders, even though these individuals make up less than half of the general population. So we see more death in these individuals. They're a vulnerable population. And in addition to mortality or death, there are a lot of other costs that are associated with tobacco use. So a lot of times we think about lung cancer deaths in tobacco users. Any cancer death is more likely in individuals who use tobacco, and lung cancer deaths are even increased in non-smokers due to secondhand smoke. A lot of deaths related to cardiovascular disease in smokers. Also in non-smokers, we think there's about 35,000 deaths per year related to that. We know that secondhand smoke exposure is associated with both new cases and increased severity of childhood asthma. Getting outside of health consequences, drop cigarettes are the leading cause of residential fire fatalities, leading to more than 1,000 deaths each year. There's a threefold increase in cancer risk for cats who are pets, and there's an estimated 1 tree lost for every 1.5 cartons produced. And why I've included these latter facts in the slide is that one of the really tricky things about treating tobacco use disorders is that the consequences tend to be very long-term consequences. You know, getting obstructive pulmonary disease or getting a cancer, that's something that tends to happen to you when you're older. So you don't think about that risk immediately. Oftentimes what brings people into treatment for substance use disorders is an immediate consequence. Something happened legally, something happened health-wise, something happened with a spouse. You don't see that as much with tobacco use, and so to help motivate individuals, you need to find real-time consequences. And these are examples of real-time consequences. Do you know how your tobacco use is affecting your children, affecting your pets? Do you know how it increases your risk for an accident with lighting something on fire or with causing an auto accident for you? Switching gears, we also know that tobacco users who drink are able to consume alcohol for longer periods of time, experience alcohol as more rewarding, are more likely to experience alcohol-related physical consequences, have exponentially increased rates of cancers, have greater cognitive impairments, and are less likely to complete treatment and meet treatment goals. And this is very important for you to know about, to talk to individuals and educate them who have co-occurring substance use disorders. Yeah, it makes sense that you're smoking while you're drinking. You can stay alert longer if you're doing those two things. They cue each other's use. Did you also know that there's an increased risk of cancer when you use those two substances together? And when you are trying to motivate an individual towards tobacco use cessation, it's really important to understand why individuals do use tobacco. Because if you don't address the reasons why they use tobacco, you don't find something to substitute for that need, it's going to make the intervention even harder. So you want to think about, is it pleasurable for them? Is it potentiating other drug use? Is it counteracting other drug use? Like we talked about before, acting as a stimulant if they're taking a sedative. People will often say it's helping with mood and stress management. They'll talk about weight and appetite control. They'll talk about concentration. They'll talk about it being a social event. They'll talk about stress relief. And they'll also talk about boredom. What's interesting is if you ask most people why they're afraid to quit, they'll say, well, what am I going to do when I'm stressed? If you actually look at why they're smoking, it's usually because of boredom. So it's going to be really important to have them address those moments of boredom in an alternative manner. If you look at a lot of the other reasons why people report that they smoke, the help with the concentration, the help with the mood and stress management, typically what's going on there is that they're actually taking a time out from a stressful situation. Hey, I got to go out and take a smoke break. They step out. They do some deep breathing. They happen to have a cigarette in between their lungs and the air. And they're alleviating nicotine withdrawal. And that's the bottom line frequently in the continued use of tobacco, is that individuals in the end are dependent on nicotine and they're alleviating withdrawal. And nicotine is super tough because pharmacologically it's as addictive as heroin or cocaine. And it differs from other drugs of abuse because a greater percentage of those who try it become daily users. 1/3 of individuals who try tobacco become dependent on that, and that's a combination of this pharmacologically addictive nature of nicotine as well as the increased acceptability and availability. So this is a figure from a review article by Neil Benowitz, and I've got the reference on the slide. This is a wonderful review article that talks about the molecular and behavioral aspects of nicotine addiction. And if we start in the middle of this figure, you see that you smoke a cigarette. We're moving across these straight red arrows. You get a nicotine spike, and then you activate these nicotine receptors in your brain. And as you move up and to the left, these nicotine receptors increase the release of dopamine. That's some of the sense of pleasure, stimulation, mood modulation. And at the same time, the environment you're in gets associated with those feelings. So whether you've just finished a meal, whether you're drinking a cup of coffee, whether you're with a particular friend, that association gets paired so that then you develop smoking cues as well as your body, when it feels stressed, remembers all the times you've smoked and alleviated that withdrawal and felt better, so you develop craving. And this continues, the cigarette smoking. Now, the other thing that happens is that when you get this nicotine spike and these nicotine receptors get activated, there's not a natural way for our brains to metabolize nicotine. Those receptors use an endogenous chemical, acetylcholine, and we have a way to metabolize that. So when the nicotine binds to the receptor, we don't have a way to metabolize it. Your brain has to shut that receptor off so that bad things don't happen, like the cell dies or you have a seizure. So you get what's called a desensitized receptor. So it turns off. And that's what leads to the decreased effect of every cigarette you smoke later in the day. If you talk to an individual, most folks are going to get the biggest effect from the first cigarette they smoke of the day because they've had all evening to have those nicotine receptors in their brain turn back on. And so then they have their first cigarette or two or three, they all get turned off again. And what happens when you inactivate these receptors, all of a sudden you've got these reduced levels of dopamine and other neurotransmitters. You develop withdrawal symptoms. You may not even realize they're withdrawal symptoms. You're feeling a little irritable. You're feeling anxious. Next thing you know, you're waiting until your next smoke break and develop that craving. So it's a very tight cycle. And I have this next slide up, again, mostly as a reference for you all for another wonderful review from the New England Journal of Medicine by Drs. Fiore and Baker, who are leaders in this field, to outline what you would want to do with a smoking cessation intervention. We're not going to focus on this, particularly for this webinar, because we're going to talk more about policy related to tobacco-free. But as an introduction to the topic, I did want to put this up here. This is a great schematic that goes over the 5 A's for doing a smoking cessation intervention. First, asking about their use. If they are using, advising them in a personalized manner about the risks of their smoking and the benefits of quitting. Assess whether they're willing to make a quit attempt, and then assisting them with a combination of counseling, medication use, as well as providing them with other resources, and then arranging for follow-up. Now, when we think specifically about addiction treatment settings, there are a lot of great reasons to treat and prevent tobacco use in addiction treatment settings. As we mentioned earlier, there are high rates of tobacco use in individuals being treated for other substance use disorders. We know there's greater morbidity and mortality in individuals who use tobacco and other substances. We know that there are higher relapse rates in smokers. I'm going to have a little bit more data about this. And we know that there's patient and staff exposure to secondhand smoke in individuals who work or are treated in an addiction treatment center where smoking is occurring, and that carries health risks for individuals. Now, there's also a lot of barriers to tobacco use treatment in addiction treatment settings. And it is not very common to have tobacco-free addiction treatment centers unless there has been some sort of regulation that requires it. So for instance, the Joint Commission has required hospitals to become tobacco-free. So many treatment units that are embedded in hospitals have either gone tobacco-free or will get a waiver to continue the tobacco use. Otherwise, the majority of addiction treatment centers, especially those that aren't associated with some of these regulatory organizations, have remained tobacco using. And there are a lot of reasons for that. There's a lot of fear that patients won't come to treatment or will leave early. I think that this is one of the biggest reasons why individuals won't pursue this goal. And I'm going to have some data that actually contradicts this fear for individuals. There are a lot of concerns that patients will be unsuccessful or don't want to quit. Concern that patients will relapse to their drug of choice. And I always, when I think about this, I hear this all the time. Let them smoke. They're working on their alcohol dependence. Now, if we had someone who came in using both alcohol and methamphetamine, and alcohol was their drug of choice, I can't imagine a treatment center that would say, well, let's work on the alcohol dependence and let's wait on the methamphetamine. In fact, why don't we let them bring in their methamphetamine and use it while they're on their breaks? Other potential barriers, concerns that it will make treatment harder, concerns that it will require too much policing, concerns that it's their right to smoke, that there are more pressing conditions to treat. That's a little bit what I talked about earlier. No, let's focus on this alcohol. in the end, I think two of the biggest barriers are that there's lack of confidence and skills to treat tobacco use because we haven't historically addressed this as much in addiction treatment, as well as elevated rates of tobacco use in treatment staff. So I'm going to go through a couple of these concerns regarding the barriers, and these are kind of the myths that the title of this came from. So myth, patients don't want to quit. If we look at the facts, 75% want to quit using, 65% have tried to quit in the last 12 months, so they're doing this. The majority of folks do it without help. And we know that we can really increase their chances of success if we offer that help. And to the right, this is a great poster series. I didn't survive depression and suicide attempts, so I could die from lung cancer. I had to stop smoking. These are free posters that you can get to put up in your clinic and really help remind individuals to address this, both patients to ask about it as well as treatment providers to ask about it. One of the other myths, patients can't stop. The fact is actually that smoking cessation interventions work. Our numbers needed to treat for smoking cessation interventions are very high. Over and over again, we demonstrate that smoking cessation interventions work. This is a graphic from a paper by Jody Prochaska et al. From the University of San Francisco that did a meta-analysis. And this is an early meta-analysis from the 90s, early 2000s. And it found that the effect of smoking cessation is that it almost doubled quit rates if it was included with other addiction treatment services. So another myth, they'll relapse if we have them focus on their tobacco cessation. Again, the fact is that relapse rates are actually 25% lower when you integrate tobacco treatment. This is from the same paper doing a meta-analysis looking at relapse rates in individuals. There have been several studies since this time looking at this. This group just had a study looking at individuals for psychiatric treatment with co-occurring substance use disorders where they integrated a tobacco cessation treatment and showed not only improved psychiatric care outcomes, but improved smoking cessation outcomes. And so in fact, addictions treatment settings are perfect for tobacco cessation interventions. We're experts in behavioral change. We tend to have folks for a fair amount of time. We're great at building therapeutic alliances because a lot of times folks are pretty early in their stage of change or in some way coerced into treatment. We are more used to doing co-occurring treatment for individuals. We have a lot of experience working in integrated models. We certainly have high access to a high-risk population. We tend to have community-based and patient-directed services. It complements our other prevention and wellness activities. And this can be an excellent performance measure. So I'm going to take a little bit of time now to talk about our experience here at CeDAR with going tobacco-free. And so to bring this back in time a little bit to the summer of 2012, as I mentioned earlier, we are associated with the University of Colorado Hospital and the School of Medicine. And in 2012, their grounds and buildings were considered tobacco-free. And CeDAR had an exemption from this policy because of the high rates of tobacco and concerns that I mentioned previously. And as we started to integrate more tobacco cessation into our programming, all of a sudden we started hearing over and over anecdotal concerns from patients who reported starting tobacco use and treatments. Again, this is probably no surprise. We heard a lot about individuals who their smoking went up when they went into treatment because they couldn't use the other substances. And we were hearing stories about our staff who were relapsing to tobacco use disorders while they were working here, being around the tobacco use and getting cued and triggered. At the same time, the culture of addiction treatment was transitioning to more of a recovery model that recognizes the importance of addressing tobacco use in overall recovery. And so that gave us some momentum to take a closer look at this. And so the first thing we did in 2012 is, as patients were getting ready to discharge for treatment, we provided them with an anonymous tobacco use survey. And we wanted to know what happens to tobacco users in treatment. So we'd ask, what happened to your tobacco use? Did you quit? Did you decrease your use? Did you maintain your use? Or did you increase your use? And we had 85 individuals respond to our survey. Again, this is anonymous. And 6% were reporting that they had quit or were planning to quit, were thrilled. Another 27% decreased their use. Again, we're thrilled. But then we had 67% that were either continuing the same amount of use or increasing their tobacco use. And we were quite concerned about this. You know, it's not common that you have someone come into a hospital setting and have an illness worsen and not necessarily have that get addressed. And that was part of our concern. And so we also wanted to find out what was happening to our tobacco non-users. And so we surveyed those individuals. We got 86, again anonymous, same survey as the tobacco users. And we found that while 95% of individuals remained tobacco-free, 5% were initiating tobacco use in treatment. And this was very concerning. I consider this an adverse event, that someone could develop an illness that in all likelihood will kill them eventually. So this really, really caught the attention of our staff and was, I think, some crucial data that we had to gain momentum in our tobacco-free transition. So in 2012 to 2013, we launched our tobacco-free initiative. We had consultation with the UCSOM Behavioral Health and Wellness Program. In January 14, 2013, we made the announcement to our referral agency and potential patients on our website and when they called admissions that we would be transitioning to becoming a tobacco-free facility on February 14, 2013. And I have here our steps that we use towards success, and these are from that toolkit from the Behavioral Health and Wellness Program. And so the first thing that we did was convene a tobacco-free committee. And I cannot say enough about including as many individuals as you can in your tobacco-free committee. And so you want to think about having individuals from public affairs, health education, pharmacy, human resources, facilities, environmental services, clinical medical directors, employees, patients, security. One of the points that we learned from in forming our tobacco-free committee is that we stand somewhat separately from our pharmacy and did not have a pharmacy representative on our tobacco-free committee. And about 24 hours into our tobacco-free transition, we got an email from them about the fact that we were about to run out of nicotine replacement gum. And so our wonderful director of operations at the time whipped back an email that said, well, what would you do if you were about to run out of Coumadin? And we were able to procure more nicotine replacement, but having had them on our committee ahead of time may have prevented that. So step 2, after you convene a tobacco-free committee, is to create a timeline. And I cannot emphasize the amount of preparation that should go into a transition like this. Ideally, you want at least 6 months and preferably a year. When we made our transition, our administration was already on board. I was working closely with a behavioral health and wellness program, and so it took us 6 months. You may need additional time if you have to achieve some buy-in with administration. So it really depends on the stage of change that your organization is in. If they're pre-contemplative or contemplative, you're going to need some more time to educate them about the benefits, study where things are right now. Step 3, craft the message. So you want your message really to be short and sweet and to get across why you're doing this. Time and time again, people will be like, why on earth are you doing this? And when I just take 30 seconds to share why with them, they respond, wow, you know, I never really thought about that way. It really makes sense. So when you share that, you can increase the recovery rates by 25%, that you can stop the new onset of tobacco use disorders. When you talk about creating a healthier environment for them, when you talk about the fact that they're going to die 1 to 2 decades earlier, that in all likelihood their tobacco use disorder is going to be what kills them, it really raises understanding. Additionally, you know, someone doesn't have to make a tobacco cessation attempt while they're here. And so if you can craft a quick message, you know, we're not saying that you have to quit smoking while you're working here or while you're a patient here. We are saying that you can't smoke while you're on the campus here. We will support you with nicotine relapse prevention. Step 4, draft the policy. And when you're thinking about your policy, you want to think about the policy regarding where are you going to be tobacco-free? Is it going to be just in the buildings? Is it going to be the entire grounds? What are going to be your requirements of staff? Some institutions require that staff be non-smoking or non-tobacco using. We are not doing that. However, people, just like other legal substances, they have to be not identifiable as a user while they are on campus. You want to think about, for your staff that are using tobacco, are there ways you can support them through offering cessation or other resources? You're going to want to think about your policy for visitors. Are visitors allowed to bring tobacco products on campus? Are they not allowed to bring tobacco products on campus, and how do you educate them? Then you also want to think about, how are you going to handle infractions? So with patients, how do you incorporate an infraction into their treatment plan? With staff, how do you incorporate an infraction into their supervision? Step 5, clearly communicate your intentions. You want to communicate early. You want to communicate often. You want to shoot for over-communicating, because in the end, we all tend to under-communicate. We started telling folks 30 days prior to our transition so that everybody coming into treatment would know it was going to happen when they came. We actually had one individual that thought that we were going to transition before we even transitioned. So you're going to want to communicate with your neighbors, outside referral agencies. Step 6, educate staff and clients, the background behind this. What are available treatments? What are community referrals for this? Step 7, provide tobacco cessation services for your clients. Have behavioral counseling as well as pharmacotherapy available. Step 8, build community support. Step 9, launch the policy. Have a countdown. Consider a letting go ceremony. Have staff on site. Put up signage in places. Step 10, you also, this is just like a quit attempt for a person. You just don't help someone at the quit attempt and then say, okay, see you later. They're going to need a lot of support, the relapse prevention. So the system needs this as well. You need to monitor the policy and respond to challenges. Now the original 10 steps stopped here. But because we were doing this in addiction treatment centers, we decided we had to have 12 steps. So we added step 11, which is a case study, and step 12, which is disseminating innovation. And that's what we're doing now, talking about what we did. So, myth, census will drop. These are the numbers of our average daily census and treatment from 2011 up until 2013 when we made the announcement, and then in February 2013 when we went tobacco free. And as you can see, our 1-year data was that we actually had an increase in census. I just tabulated our almost 2-year data, and it was no change in census. It was non-statistically increased. Myth, patients won't enter treatment, and so the concern is, well, we'll get all non-smokers coming to treatment. So this graph shows that before our tobacco-free transition on the left, we had about 50% of people coming into treatment were tobacco users. So now we see after the tobacco-free transition, same amount. There was no decrease in access to care. So we had no development of tobacco dependence while folks were in treatment, so we prevented those adverse events. And our quit rates went from 6% to 54%, 9 times higher quit rates. That's huge when you think about an outcome. I cannot tell you how many people said, wow, I didn't realize that NRT was going to work that well. Wow, my breathing got so much better when I was trying to exercise. I really want to hold on to this. And then this was another great outcome. This was an anonymous survey that we did with staff that looked at their tobacco use after the transition. And as you can see, we did have about 11% using tobacco more with the transition. Over 60% started using tobacco less. Over 20% quit using tobacco. We were just so thrilled to see that. We've got over 30% making a quit attempt and 50% seeking treatment. So this was such a great secondary outcome. And again, that highlights the idea that behavior change is a parallel process. So this addresses that concern that because there's a high rate of tobacco users in this field, some of our decreased interventions related to tobacco cessation are probably due to that. And as we can get individuals in our field to obtain tobacco cessation, they're going to be more likely and more confident about making interventions with others. And this is an evidence-based finding. And so our post-transition tobacco-free CeDAR had an improved census, we had improved treatment, we had improved quit rates, we reduced our adverse events, we reduced our triggering, and we reduced our exposure to secondhand smoke. So now I'd also like to mention a little bit about electronic nicotine delivery devices, because this question frequently comes up. And, you know, there's some good, there's some bad, and there's some ugly with electronic nicotine delivery devices. And how I think about them is a lot like I think about electronic medical records, and that the promise is great. The current implementation isn't where I would like to see it. And that's what I think about electronic nicotine delivery devices. So this is an older generation e-cigarette. So it's a battery-powered electronic device that provides doses of nicotine in a vapor form. It's got ingredients in the vapor including propylene glycol. There may or may not be nicotine, flavorings. And as we're learning more about e-cigarettes, we know that there are more additives being used, chemicals, to increase the flavoring and the addictive nature of it. And we really don't know a lot about the health risks. There's increasing research of the vaporizing causing respiratory irritation at this point. And one of the things that I'd like to highlight are the public health concerns related to poisoning. A lot of these devices have containers that you can refill them with, or if the device gets like chomped on in some way, can cause a poisoning. And the dotted line on this graph represents poisonings related to cigarettes, which, and these are calls to the Poison Control Center. You can see those are, they stay pretty steady. And if you look at the solid line, from 2012 to 2014, it's starting to skyrocket the number of poisonings related to e-cigarettes. And whereas cigarette poisonings tend to be in children who consume butts, we get that with e-cigarettes, but we also get a lot more adult poisonings because of misdosing. And there's data not represented in this chart that this is the first year that e-cigarette poisonings have actually outnumbered cigarette poisonings. And as this technology gets picked up, it's going to get worse and worse. So this is a case report from the New England Journal of Medicine of a 10-month-old boy who ingested a small amount of e-liquid nicotine and was treated in the ICU. And they did an analysis of the median lethal dose. And 1 teaspoon of a solution that's used in these e-cigarettes could be lethal to a 90-kilogram person. That's you know, probably around 200-pound person. Highly lethal. Pets have been killed. Explosions occur. One e-cigarette exploded in a car, landed on a child's car seat, started a fire. One e-cigarette exploded in a gentleman's mouth, knocking out his teeth. And so when you're talking to your patients about e-cigarette use, you know, if we get this product regulated into a better place, you know, the use of nicotine is going to be healthier than the use of tobacco because of all the additional health risks of tobacco. However, e-cigarettes are not currently regulated. They're not approved. We haven't had the evidence base showing that they're an effective tobacco cessation product. There's also some early evidence that the use of e-cigarettes may negatively impact tobacco abstinence. We don't know really what's in these vapors yet. We do know that bans are increasing and that e-cigarettes, because of the poisoning concerns, should really be secured in the same way that other medications and controlled substances are secured. So I've included on this slide provider resources. I really like the Tobacco Dependence Treatment Handbook as well as these other resources. If you are going to integrate tobacco cessation into your addiction treatment center. And these are some additional provider and patient resources. I've listed the Colorado Quit Line. That's actually a national quit line. You can get free NRT, some groups. And I thank you for your attention. We're going to open it up for some questions now.
Great. Thank you so much, Dr. Martin. This was an excellent presentation. We've already had a number of questions come in from the audience, but I would like to remind you that if you just use the Q&A widget below the slides on your screen, you can submit a question. One of the most common questions coming from our audience today has been about getting those posters. Can you give us a resource for how they can get those fantastic posters?
Yeah, you know, as I was talking about that, I realized that the print on that actual poster was too small for me to see, and that I would probably be asked about that. And I can't reach, I have some of those in the cabinet behind me. And so what I can do, if there's a way I can get you all the information for getting those, then I can help them out with that. So typically, like if you go to the American Lung Association, the American Cancer Association, they can connect you with those resources, and I'm happy to follow up with an email for getting those posters. There's some great posters as well that you can get that list the benefits of quitting smoking, so that they'll say, you know, within 48 hours to 72 hours, you get your sense of smell back. Within 10 years, your risk of cancer has declined in half. Within 15 years of quitting, your cardiovascular risk has decreased to that of a non-smoker. So I can get you all of those resources, and I'm happy to do that.
Fantastic. I know we would definitely appreciate it. So on to the next question. What happens when staff or patients break the rule when they are smoking? What can you do to support them, and how do you manage that?
Sure. So taking the patient first, what we do is we integrate it into their treatment plan. And so this can potentially happen in a number of ways. It might be that tobacco ends up surreptitiously on the campus. It might be that an e-cigarette comes onto campus, or someone transitions to oral tobacco use. And so first we'll make sure that it's being addressed. And so we'll have the counselor, in addition to one of the docs, sit down with a patient, talk about what's going on, try to figure out, you know, are we under-treating your nicotine withdrawal with nicotine? Are you craving? Do we need to add an additional medication like Chantix or Zyban on? Are there some more behavioral interventions? You know, can we help your accountability by checking your lung carbon monoxide on a daily basis so you know you've got that extra level of support? And then we'll also use that as an opportunity to look at the greater picture of their addiction, because almost always the tobacco use related behaviors are indicative of the overall addiction state. And we have, on rare occasion, I can only think of once or twice where we've had a smoker or tobacco user actually leave treatment and transition to another facility. And each time it was not just the tobacco use. It was also associated with a pre-contemplative state of change and other behavioral difficulties. And so it wasn't so much the nicotine dependence per se that was associated, but the overall active addiction. So regarding the staff, we have used a policy where if someone smells of smoke, they'll get a verbal warning. If it happens again, they'll get a written warning. If it happens again, then they can be subject to disciplinary action. It has never happened. We have had times where we've had more staff who are using tobacco start to smell again like tobacco. And one of the, I think, more creative things we did is we actually, at one of our staff meetings, we ordered a bunch of pizza, and we opened up the tops to the pizza, and it was at 5 o'clock, so you could smell the pizza, and everybody's like stomach is growling, but we didn't let anyone eat the pizza. So it was like a real life experience of what it would be like for a smoker who can't smoke to smell the tobacco smoke on someone else, to help give them an experiential idea of what that's like and to talk about that. And we hadn't asked those individuals to fast for several days like the non-smokers.
Wow, what a great experience. On to another question. Are your patients assessed upon admission for their tobacco use?